Let's do an initial kickoff. I'm Jenny Reindorp. I'm Interim Director of Programmes at NHS Providers, and I'm really delighted to welcome you to this first event in our new programme on provider collaboratives improving equitably. The focus of the programme is very much on sharing peer learning through events and resources to help board members and senior improvers working across provider collaboratives to use shared improvement approaches to tackle inequalities while you drive progress against key operational priorities. And we're very delighted to be joining forces with the Q community with support from the Health Foundation on this programme, drawing on their many years of experience of working in continuous improvement, and of course the Q community as a connected network of improvers across the UK. So very much a team effort. The programme is also supported by NHS England, which enables us to link in with all the learning from the National Health Inequalities programme. And it's also, of course, in the context of NHS England's renewed focus on continuous improvement at all levels of the service as part of NHS Impact. So in terms of the focus of our session today, you just see from this slide there, we're going to look at lessons from work at trust level to harness the power of quality improvement to address health inequalities. And we want to be really practical and look at what that really means, what it really means to bring an equity perspective, and specifically to focus on what role board members can play in helping to really hardwire this focus on equity into your existing and new improvement work at trust level, but also thinking about how this might begin to be applied in your work in partnership across your provider collaborative or numerous provider collaboratives, recognising that that's early days, but how can we begin that thinking now? In terms of people on the call, it's great that we've got a really good mix of board members, exec and non-exec, as well as those working into the board, programme provider collaborative programme directors, quality improvement leads. So welcome to you all. This is designed to be an interactive event, not just a presentation. So do please come in the chat with any questions, any comments, any thoughts from your own experience within your trust or provider collaborative. Do also raise your virtual hand. After each presentation, there'll be time for questions, but we really welcome your comments and reflections, and we will share a recording and these slides in a post-event email, so don't feel like you have to scribble away throughout the session. So without further ado, let me introduce today's speakers. We're very grateful to you for coming, and we know it's an incredibly pressurised time across the service, so thank you so much. So we've got today Andy Snell, a consultant in public and global health and a doctor in emergency medicine, and Bob Curtin, who is Chief Delivery Officer and Deputy Chief Executive, who are both from Barnsley Hospital NHS Foundation Trust, that's part of the South Yorkshire Acute Provider Federation. And we have Beckie Byrne, who is Associate Director of Transformation from Lewisham and Greenwich NHS Trust, and is also a Q member. So thanks once again to our three speakers, and I'm going to hand over to Andy and Bob without further ado to kick us off. Thanks, Andy.
Thanks very much. I will try and share my screen and then kick off. So I'm Andy Snell, and I've got a bit of a mixed role because I work with Barnsley Hospital, which is a joint appointment with the council, and that's split with part-time, because I also work with WHO Regional Office for Europe and do some clinical work, and that's a real pleasure for me because it gives me a bit of a kind of gradient on across the whole spectrum of health, right down to the individual, up to kind of the direction that we're supposed to be trying to take things. And I job share with Carol Harwood, who's another public health consultant at the hospital. So I think that's also worth noting that there's been quite a kind of significant investment into public health taken by the hospital jointly with the council, but that's sort of down to, in my view, a good value investment. I hope not because of me, but because of public health skills that can be brought to it, and that requires some leadership with the likes, which the likes of Bob brings to this. And you'll hear some wise words from Bob after I've gone through some of the health inequality stuff. Now, I mean, it's a pretty big issue to be addressed, and it's a pretty complicated one. It's quite a technical one, and it's it's wicked. So I have gone for a bit of a 101 here. The slides will be shared, so some of the detail, especially about the QI approach, you can get from the slides afterwards, or indeed by contacting us. But I'm also very open to kind of challenge your questions and clarity. I know we've got some Q&A time, so I'll try and keep an eye on the time. I think you've got me for about 15 minutes. So so quickly, what do we mean by equity and equality? I think this is important, and this American cartoon gives us some idea. So people with different circumstances might have a different outcome from an equality approach, which is there on the left. Some of those people get a better chance to have a good view of the game versus others. And so an equity approach, which is quite an important difference, is taking equality and developing a fair approach to it, so that people's circumstances are incorporated into how we develop services and systems, or in this case, how we support someone to watch the game. On the right, if we're getting a bit radical, is perhaps what the reality is like in many countries, including our own, which is that people with circumstances that might disadvantage them, even in an equality-based approach, actually are further disadvantaged, and the opposite is true for the other end of the spectrum of the most advantaged, and that is a real issue. And some of those things are beyond the scope of healthcare providers, but some of them, and this is what this is about, are really within the scope of healthcare provision. That's important. You could take a social justice approach and say that fence shouldn't be there at all, and these people should be in the crowds with the others. But there's a conversation for another day. So the sorts of circumstances that guide where you stand in that picture are personal characteristics, social and economic factors, and how society or others treat us. So other characteristics we have that lead to discrimination or exclusion in other ways. And in this country, we have a fantastic tool to gather many, but not all of those characteristics, and inform the system, like a healthcare system, where we sit on that kind of social gradient of inequity based on that range of circumstances. And that's the English indices of multiple deprivation, which goes right down to postcode level. And there's no reason that we can't incorporate something like this into healthcare planning and delivery. And that is kind of what's behind the Core 20+5 idea that the NHS has adopted and is encouraging us all to do, is a sort of build up from the NHS long-term plan on prevention and reducing inequalities. Core 20 being the 20% most deprived people in the population, and the plus being some specific characteristics relevant to our local population that might add to exclusion or discrimination or inequality. The 5 clinical areas, less important for me, because the Core 20+ is true across all care pathways pretty much. And if we develop them in a way that supports people in the Core 20+ population, we'd be improving quality and equity. So a bit more about equity, because I think it is important. This is the King's Fund kind of summary of what health inequalities or health inequities are. They are unfair, so there's an ethical case for doing something about them. They are systematic, so this is not kind of individual choice-based stuff. This is the way that systems, including health services, are designed around people that cause these inequities. So it's not up to individuals to fix the problem, really. And they are avoidable, so we can do something about them. And that's true for the health side of inequity as well as other aspects to it. This is the national data. This is from pre-pandemic, so it's probably got a bit worse, but the left-hand side of these charts are the most deprived people in the population. These are 10%, so these are deciles that make up the whole population from 1 to 10. And the left-hand one is probably the most important. The more deprived you are, the shorter your life expectancy is, quite significantly so. But also, really importantly, and very relevant to healthcare, the longer you will live in ill health, not proportionately actual total number of years lived in ill health. So those dark bars at the top of those charts are what we see in healthcare, that this is driving demand for healthcare and driving it in the wrong direction and making services like the NHS not able to keep up with demand because of inequity. And there's lots of evidence now to prove that. And sadly, things are getting worse in this country. So the right-hand chart tells us that the more deprived you are, the worse things are getting. So life expectancy and healthy life expectancy is getting worse for the more deprived group and better for the least deprived group. Again, that's because of systems, and we have a degree of control over part of that system. I'm not going to do the speech bubble thing, but it's just to say, if we took one example like nutrition, malnutrition, including obesity, we would see that these social gradients play out in very real ways. And that, as we know from the recent Health Foundation stuff, things like obesity is going to be driving things up in the wrong direction from points of multimorbidity and unsustainable demand. To address that, we need to address health inequalities. So systematic, well, we know, and it's a really powerful thing, that about 20% of what determines our health through our life, including illness, is our access to healthcare services. So that's a real privilege for us to be able to address that. So that's the bottom middle chart. But we also know that actually what's driving health inequalities, about 10% of that is access and quality of healthcare. And so that is the harm being done. So I certainly took the Hippocratic Oath when I qualified for medical school. It said do no harm. And there is something, not consciously so, but in the way that we deliver healthcare services, that is actually unfair, is doing harm, and can be changed. It's incredibly costly to the system. That top right is a kind of EU figure when we were in the EU. And the bottom right is really just demonstrating what it looks like, this inequity in healthcare. So the people who need healthcare most tend to get it the least, and that's what the data tells us. And that requires a conscious rebalance of how we develop systems. Again, the nutrition example is that the core 20 in our population would have to spend nearly all their income on food if they were to follow the NHS recommended healthy diet, and that's probably got worse since the pandemic and cost of living. So it's avoidable. We know we can cost up the interventions that improve things, and those on the left that are costed up are not just healthcare, they're the whole system. But we also know the stuff behind the core 20 plus is evidence-based, that we can do stuff in the healthcare system. And again, there's good examples of that for the nutrition angle. So the way we're taking this taking the approach at the hospital to try and strengthen what we do, and actually this shows that we're taking it across the whole partnership, place partnership in Barnsley, because we helped to write the Inequalities Action Plan for Barnsley, is across 3 tiers, as I lovingly call them. We try and increase the services that we can offer to patients and the workforce that will help to address drivers of inequalities at the point of care. And some of those are preventive services, some of those are social and economic support that we can identify people need when we're delivering care. Tier 2 is what we're here to talk about today, I think, largely, which is we can take a real quality improvement approach across all of the services that we deliver, because healthcare is really important for health and we deliver it very well, but just not always to the right people, to improve how we get our healthcare services to the right people in the right ways, to the people who need it most first. And then tier 3, just for note, is our wider influence, you know, the anchor institution kind of idea, that we influence local economy, local social mobility, local environment in very positive ways already, but we can do more through our employment policies, our sustainability policies, and through our procurement policies to support the local population and economy in ways that it might need. And Barnsley's certainly got a good case for that, but most of the places you work will have. So why are we doing this stuff? Well, for me, it's really important. I do believe that it's not only the right thing to do, it's clinically very relevant. And there's a couple of things there that show you that deprivation is a direct clinical risk factor for health. And if we don't address the circumstances that cause deprivation and inequality, we've got less chance of treating the disease. The disease will have already presented later. We know that. It gets greater complications. There's greater complications from the interventions we do to try and address the disease. It will ultimately lead to more reattendance and readmission. And with all of that, people tend to churn, the ones that are exposed to inequity, through the unplanned urgent care system much more than through the planned care system, even though they've got greater need for the planned care system, unless we redress things. And that is driving demand in a very unpredictable and unsustainable way, which you all know are very familiar with and suffer from. Those are a couple of charts that just evidence some of that. So what's our approach? I'll try and get through this relatively quickly, but we can talk about the detail either in Q&A, or you can look at it later or contact us afterwards. Well, we take a pretty classic QI approach, which is we want to create fairness in the access to our services and the information we provide, in the experience people have, and in the outcomes they get from it. And so we do a number of things. We look at a problem definition because it requires us to come down to the detail. So an example here is we know that people who don't attend appointments, the ones from the more deprived populations or communities or those excluded, tend to be the ones that have higher DNA rates. And rather than thinking that's just because they're annoying and misbehaving, we think, well, that seems to be a marker of unfairness, probably a red flag in many cases. How do we address things better? And on the right, just to let you know, this is kind of what we're integrating into our quality goals at Barnsley more generally. So we should be looking at equity as part of internal performance. You know, if we're not delivering equitable services, then we're probably not just equal, not universal, but equitable services. We're probably not delivering services in as good a quality a way as we could do. To address that problem, something like the DNA rates, we need to speak to people, and it's hard to speak to people that find it hard to access services by default. So we need to work through other partners like VCSE. We need to make sure our approaches to speak to people are inclusive. And we need to think about how if we're bringing lived experience into service development, for example, how we really value that input, because a lot of these people are often already struggling. We don't need to be charitable, but we should reimburse them for the insight they're providing us. But actually engaging participation and sort of co-production is a key part of QI approach for equity, and it's not an easy one. And then we need to, beyond only insights, look at the very rich data we have in a hospital to understand how our services play out and where they are inequitable, what the gaps are. And then we start to think, if we're addressing something like the DNA rates, what are the problems that lead to that DNA rate, and how can we develop a QI approach to address them? And then when we do intervene, we need to make sure we know what the outcome is. So we can run flowchart, we can run charts to make sure we're watching things like the outcomes from equity, like we do the outcomes from other things. And then we set a target. We say, well, by 2023, we're going to have a reduction in DNAs from the most deprived population. And that really leads to a practical QI approach that leads to an intervention. We need to measure to make sure we're not making things worse. A lot of things we do with best intentions make things worse. We want to narrow the gap and certainly not widen it. We do want to improve things for everyone, but this inequity gap is a real issue at the minute. And this is just an example from real data. So a service that has continuity into the community, that was designed really to help people in greatest need, we realised was being accessed by them least, and the most affluent were getting better access, and that gap was widening. So we looked at the wider issues that were going to benefit if we addressed this problem. It wasn't just about the pathway and its clinical outcomes, it was other aspects of people's lives. Did a bit of work to engage with those people. I won't tell you exactly the details of the service, but it was mothers, and that has led to understanding who they are and where they are. And now we were planning already to develop the service further. We can show which communities that service needs to reach into physically, geographically, and then we add on to that the kind of assessment piece. I'm going to stop there. I hope I haven't gone over my time, and in my last animation I will hand over to Bob.
Great. Hi everybody. So Bob Curtin, Deputy Chief Exec. I think the first thing I really wanted to say was, we're not experts. We have shamelessly borrowed from other people, and I think and we've learned a lot from mistakes. Boy oh boy, we've learned a lot from doing things wrong. But I think that's what's really exciting about this area. It feels very culturally driven. I'm not necessarily sure it's the national agenda, but it's the NHS's agenda. And I think sessions like this are absolutely fantastic for learning from each other and taking it forward. So when considering the role of the board, so I've been a board member for 10 years now. We told three key tasks of the board are assurance, strategy, and culture. I think it's really important to understand, actually, when you really think about this, that this area hits all three areas. From our experience, some common challenges have been the current system is still really based on first past the post. That does present some challenges at board when trying to explain, possibly we won't be taking that approach on every occasion. I think probably, and it really requiring a mindset change. So I think my time as a coup, you lived or died off several targets. One being a two-week weight breast symptomatic target, which is a really, really important target that we endeavour to hit all the time. It's really crucial. But actually, I'd say now we focus just as much on breast screening and ensuring women get access at 47 in Barnsley to the first breast screening test. And I would like to reduce the age to reduce the risk, and getting teams to think about who is accessing that service and not accessing that service, and getting board to think about that as much as anything else. Another challenge around culture. I remember a really early conversation with one of our clinical directors, one of my favourite people, Ahmad Masri, who's a general surgeon, and we were talking about prioritising surgery, and he said, a hot gallbladder is a hot gallbladder is a hot gallbladder, Bob, you know, like why are we overcomplicating it? And I think that so much of this is about understanding the detail and looking at the right things to change, because of course an urgent operation is an urgent operation, but actually when we're looking at the delivery of planned services and who's being seen and not being seen, that's where, you know, that's where you need to get into the detail. And then thirdly, from a strategy point of view, certainly for foundation trusts, there's been an over focus traditionally on competition. Certainly I've got caught up in that in the past, and really getting boards to understand the switch to collaboration. Obviously it's written in law now, but there's a big difference between, you know, kind of that and translating that into a you know, an understandable, translatable strategy at an organizational level. So everyone's got an important role to play in this, but it's really important to work with your board on it, and boards are changing. I think that there's certainly lots of different types of board in the country, but you're seeing a lot of more people coming into boards that are being in housing and third sector. We're hearing ex-public health directors getting non-exec jobs, some really different people coming in to the board makeup, and they're real assets for this change in terms of the overall goal of bringing equity into focus within the current context. And I think equally it's important that that conversation is held with partners, so it's a joint mission. Yeah. So the second point I wanted to make was about telling your story, and this really is crucial for having the common purpose with partners, board members and teams on the ground. Andy's already talked through the 3-tier model. We found that really helpful, and what's great is partners have taken it up. They've looked at it and gone, well, that makes sense. So what that does is it brings a lot of disparate things together. So really looking at prevention, changing current services and the approach and angle that you take on those services, but also the wider role for the NHS, which traditionally we've not really done when you consider, our role as an employer, how we spend our money, the resources and assets that we have, and the influence that we have on a local area. So really thinking about how we affect the economy and society. And there'll be other talks, people have been on anchor institutions, so I won't go into all of that. But crucially, I think what was important in the slides that Andy presented was it was presented in our context as Barnsley 2030, which is a cohesive branding that we use with not just public sector but private sector and third sector partners as well. I think it does resonate with the public. People, we tell stories around Barnsley 2030 and our aspirations and what we're trying to achieve. So I think that really brings it together with the board, with board members. We have done a number of different presentations on this issue, and certainly Andy did whiz through the slides, but that you will get them and you'll find them really interesting. But you'll see, crucially, they're a real mix of the narrative, which is important, but also data. Show me it makes it a difference, but also pictures, because you're really appealing to a wide audience. I would say people that have signed on to a session like today are kind of clued into this and are kind of, you've bought the ticket and you're on board with it. Sometimes in the boardroom, you don't get the feeling that everyone's kind of with you, and we're working really hard to get everyone in the boat around it. And again, I think we've learned a lot through trial and error on that. So that was important. And I think within the board conversation, for us, sometimes on these talks, you get the feeling it's like a competition to see who's got the toughest circumstance. And I know there are areas that are far harder hit than Barnsley, but we have got a challenged community. But we've also got a really strong and vibrant culture within our community that we're really harnessing. I think we're trying to get people to understand that equity is about us working harder to make it fairer. So this fueling this aspiration about providing the best offer that we can is really appealing to people. But also within that, this isn't some patronising monoculture. We're trying to help people to help themselves. So we're really thinking about that. Probably the best example I can think of is the work we did with all partners in Barnsley around more money in your pocket as a response to the recession and the challenges facing people, where we use a collective asset of a website and literature to appeal to people, and tens of thousands of people in the borough access it and use it. And it was really used as a cohesive force to get all agencies to work together. And we're starting to achieve some of this around the equity agenda as well, which is really exciting. I think kind of the final question within the board context is, how well informed are your board? How well informed are they? Because again, it's a bit like the issues around inclusion. What is the profile of your board? There will be a mixture of people, but generally more affluent, more more educated, more aspirant potentially. It is a challenge. So here's your facts and figures, your narrative and your picture, but actually, how do you feel about this? How does this sit with you? How do you get to understand how it feels and what the issues are? And within the group, there will be people that have amazing insight, but we also need to reach out to other groups and get the lived experience of both staff and people. So that's the challenge that we're really looking at. And we've planned it. We've done events and we've learned from that. We're doing a big event with senior leaders at the end of September, where we're taking them out into the community and using experts to inform thinking around it. So again, the formats you use, clearly workshops are a good agenda, but a good format, but also socializing it to create the ownership. And I think we've been really pleasantly surprised by the take up within the organization of the keenness of people to do it. Certainly with partners in Barnsley and across South Yorkshire. It's been great working with people on this agenda, and we look on in envy with some of the work that's happening in West Yorkshire with their academy, and that supports people, staff's understanding around inequalities. The work that Colin Huddersfield have done around people with learning disabilities. It really kind of it really drives us forward. The final point is just in terms of making this stick. I've not talked about leadership, but I hope you've got what I've inferred. This does require strong leadership and real commitment. We're really lucky. We've got an amazing chair who has really taken up this agenda and has really supported conversations on it. The chief exec is equally committed and is really supportive of the work, which makes it easier. But I've actually found within the board context, there are keen on executives that have really got behind this and helped to motor it. They're very interested in it. They want to know more. They want to know how they can help. And they're crucially bringing in an external experience and perspective that is really helping the work move forward. I think also the board support for investment. I think we've learned to our detriment to not have accessible analytical support for the work is really detrimental. Obviously, what we're trying to do is embed the work into the day-to-day reporting, and we're getting there with that. And we have an information team, but I think we need someone. I think we've needed someone really specialist to work with people to kind of find the right solutions for it. Clearly, having as evidenced a public health consultant accessible is really helpful. I think we've helped influence through the work that Andy and Carol have done. They've influenced other organisations in the region to recruit public health consultants, and people are finding their work, finding their input really helpful. I think in terms of insight, education, inspiration. For me as a kind of hard-bitten chief operating officer, the conversations I've been having with Andy and his colleagues over the last 5 years have really helped. And I'd like to think in a way it's really shaped their approach as well to finding tangible solutions that will make a difference to people as well, that will appeal to frontline staff and do the things that we want, a QI approach, which hopefully you're kind of getting the flavour from Andy's slides, having an agreed methodology, having the team support it, because if you want frontline teams to change, you need to give them the tools to give the job. It's a pretty obvious statement, but hopefully you've got a feel from Andy's slides about how we're building that approach into it as well. And we've thought about the same issue from a sustainability point of view as well. And just the final thing as well is really celebrating success. We found that in this really difficult time, the work we've been doing around inequalities and ensuring equity has really made a difference to staff. Equally the same as the work we've done on inclusion and sustainability. It actually, staff are taking a lot of pride from it and really enjoying working with other partners on it, on this work. So we've made sure we've really celebrated. And I think for us, we've done some work around a community diagnostic centre in our town centre, which is, kind of everyone is, seen as a big success, and we're trying to help others learn from it. And certainly, it's certainly helping drive foot forward in the town centre and make a difference that way as well. So they're my key points. Thank you very much for listening to me.
Fantastic, Bob and Andy. Can I just say it's really inspirational hearing you both talk and how much has been achieved, and that focus on the kind of mindset shift and how you've brought people on board is just very compelling. So thank you so much. I'm just going to bring in some questions from the chat, and if you have posed a question, do feel free to also come in. So just Sophia Murphy, great question about how did you approach board members that perhaps are a bit more resistant? It sounds like you've actually got quite a lot of buy-in from your execs and from your NEDs, but are there any other tips that you could share about how you got alignment across the board?
Bludgeon them. I think that the chair, our chair, has been absolutely crucial in that, and I think the time that we've spent as a team working with her, the lead governor, we report this work through our quality and governance committee. So the chair, Kevin, the chair of that committee, again, he's really adopted it. But it's a team sport. So I think it's a really great question, because you bring that into the wider trust board discussion. Well, how much is that costing, and what's that doing to our performance, and how does that work? And I think that's where the workshops and the context and understanding, you might have this shiny hospital, but it's actually in an area of high deprivation, and there are a lot of real life issues facing people. And I think that I think we've created a momentum that's undeniable, but I would say, working one-to-one to explain it and using the people that are closest to the issue would be my tip.
I've written down the answer to two questions, really good questions in the chat, which is kind of speak with them, because it sounds ridiculous, but it is generally so important. Like, it hasn't always been the case that everybody across the leadership at the hospital or elsewhere, isn't necessarily all totally the case now that everyone is on board. But speaking with them and making sure it's relevant is key. That this is why I've sort of started to say every time I talk about inequity, which is not the whole of public health by any means, nor the whole of what a hospital can do in the public health sphere, but it is clinically relevant, and it is relevant to demand management. So the stuff that a board is duty bound to try and address for a hospital, this is integral to that, and there's lots of evidence to suggest that not only is it a driver of making things worse at the moment in that clinical sphere and demand management sphere, but there's also things we can do about it. And so sitting down and speaking with people and then addressing things in a relevant way is key to me, and that tends to bring people on board. And then supporting that, like Bob says, with the development stuff. It's not always easy. Like, I've learned over the last 5 years that I've shied away, not at the hospital, but from certain people in leadership positions who are very quick to challenge this. And I'm slowly learning even now that even those people, if you sit down and speak with them, most people in healthcare are there to improve people's health. So if you make it relevant, if you understand what motivates them and what their experiences are, then they'll tend to come around. It's a slow game.
Thanks, Andy. Thanks, Bob. And that's a great question from Sophia. Deborah, I wonder if, did you want to come in and make any other comments on your point there about changing perceptions and empowering staff in that way?
Yeah, it was really just about the fact that that when you sort of think about DNAs and you think about the things that are causing the inequity, there are certain perceptions, I think, that healthcare workers have around why those things are actually happening, which isn't always, I think, the truth. I think from what Andy was saying earlier on, you know, when they've gone out and talked to the people that that are in the more deprived areas, they've probably found out a lot more insight into why things are happening rather than the assumptions that we make. And I think the changing the perceptions of those individuals and what's going on, why things are happening the way that they're actually happening, is really key, I think, for changing the way that we all work and that we all approach this inequity. And it was just that I just was wondering if there was any insight really into things that had really worked well in changing staff perceptions and helping us to really achieve what we need to.
Thanks, Deborah. Andy, Bob, any other reflections?
Yeah, definitely. Bob, do you want to come in first, or shall I?
You got-
So, I mean, I think, again, that was the other question that I wrote, speak with people. So we've talked a lot about boardrooms and execs and all that, and that's really, really important. I've had a lot of support from that space, but it's the detail on the ground, which I sometimes forget, that's most important. And that's where whole workforce comes in. Again, most of these things, when you actually go along and speak to people and have an open conversation with staff around why you're suggesting doing stuff in certain ways, even those that will challenge you at the beginning, they're often very important challenges. You'll come to a kind of understanding with them and they'll see. So, for example, like one, highly controversial area is, do you incorporate things like deprivation into clinical decision making? Like, I don't know, two people who present with the same clinical problem, clinical sort of presentation, do you change the way you approach or even put them on the waiting list based on things like deprivation and other things that lead to social exclusion? Now that's loaded. That's a massive question. It's loaded. Initially, people will say, well, hang on a minute, are you saying you're going to disadvantage someone because they've got a higher income? If you say, well, no, but if those two people, one of them, because of their circumstances, is already presented a bit later, actually, because they don't have good access to primary care, has greater complications because they have wider risk factors beyond only deprivation. And if you leave them in their current condition for longer, their lack of sick pay because they're on a 0-hour contract is going to spiral them down into poverty versus the other person who doesn't have any of those issues. And that actually starts to bring what we're talking about here into the clinical space, into clinical decision making. But those wider circumstances, which are directly relevant, we rarely incorporate at the moment because of the way the system's set up. And people will then start to nod and understand you. And a lot of the staff actually on the ground, when you start to explore these problems, they experience them in the patients that they see. They might experience them themselves. When you're having these conversations, you go around your grand rounds, you go around your junior doctor teaching, you go to your ward teaching sessions and huddles and all of that. Not as much as we should, but this is where you start to have those conversations. You then start to find, I don't like the term champions, but real advocates who are going to really take on the QI approach. And yesterday, I was having a conversation with one of our trauma and orthopedic consultants who's desperate to get this stuff integrated into their T&O pathways, with a focus at the minute on addiction and housing deprivation. And suddenly you've got a new pathway in a T&O area where you would have maybe thought, oh, won't address there for a while because they're, our stereotype of T&O is different. So speak to people and generally you'll make things, take things the way that between you that is the right way to go.
Many thanks, Andy. That's a great question and answer. I'm wondering if we could just combine a bit of Mo's question and Tamsin. Got some great questions in the chat. Because Mo was asking about how you galvanise partners and internal teams to get buy-in, and I think we've picked up some of those key threads. But I was talking about how do you evaluate and share the data that you've got from on progress with the board. And there was a question from Tanzin on how do you make sure teams have got access to the data that's going to help them identify where you focus the energies when there is so much to run at. So I wonder if we could take those two ends of the telescope, how to use data to know where to place your bets, and how do you then report back to the board on progress. Bob, should I pass that one to you? And then Andy, do come in with any other comments.
Yeah, okay. Well, I'm going to be really honest on here. So I think one of the things that we had was we worked a lot with local agencies around COVID. So we looked at the most vulnerable. We agreed permissions with the council and other bodies to get the best profile of people, to really understand what was going on for people during COVID, lockdown, etc., and how to ensure we access the right people to give them support across the borough. And we really wanted to extend our thinking around that by creating something called the vulnerability index. So we got the kind of the richest picture of what was going on, and it's been impossible to do it. We still haven't given up that dream of doing it. It requires investment at the council end, and we can't cover it off. There's a desire to do it, but it's going to be really difficult to do it. So we're finding, we're not, I suppose, is not letting perfection be the enemy of good, and there's other information that we can use to do it. We definitely have to, when we have an analyst that's focused on this, it is easier, but I would be really keen to normalise the reporting on it as well. So it's a bit of an education job for people. But we're rapidly coming up with a standardised way of reporting it. So the QI approach is really good, because otherwise you have a scattergun approach, and the step that Andy unapologetically sort of put up said it's the simple go back to basics approach: plan, do, study, act. Use those steps to work through what is the problem you're trying to address, how will you know you've resolved it, and all the rest of it, and putting the measures in that way. So I definitely think for all the right reasons, we've overcomplicated, and actually it's quite a simple job. And then in terms of the board, we've had a real evolutionary approach. I think we've settled on a really good approach that we do now as well, is saying, we want to address health inequalities. Everyone gets excited and they like that conversation, but then how are you going to do it, and how are you going to focus? Are you just going to do good, or what are the specifics you're going to do? Because once you start getting to the exec team level, the assurance committee level, people really want nuts and bolts, plans, metrics, dates, names, all the rest of it. And I think Andy and the team have done a really good job of that, talking through, giving examples of things that we're doing for each of those three tiers, and that plays through. And partners really understand that as well. They've taken up the model, and we're sort of using a similar way of reporting on it. Hopefully that's answered your question.
Yes, Bob, and thank you for the honesty.
There's so much we can do without the really detailed, sophisticated stuff. So the household level index that Bob talks about, I'm really keen to develop, but we've got IMD already, which captures loads. We know people's ethnicity and other issues that drive some of this. And you can put those metrics into how you monitor activity in your services. That, combined with speaking to people, you can measure the gaps. And yes, you need to protect a bit of your information, BI capacity to do that. You need to work with your public health partners to do it. But if you make that part of routine reporting into your performance reporting, quality reporting, then it becomes something that you are accountable for. So it can be done even now. Don't delay.
Thanks, Andy. Stella, I can see your hand up, and we've also got some questions on the chat, but I wonder if it's possible to just kind of hold on, just so that we, I don't want us to time out on our next speaker, but I'm hoping that we'll then have a chance to come back to your question. There's also some really good points in the chat, that we might be able to pick up some of those. There's a great question about shadow board as one of the ways to, again, challenge the mindset and thinking, and the kind of ability of the board to engage as inclusive leaders. So I hope we'll have a chance to come back to those questions, and your question as well, Stella. I'm also kind of wanted, if we can, to have a chance to loop back to say, what do we think the opportunities here might be across provider collaboratives, if we're thinking this is about hardwiring this focus on equity into everything we do at all levels of the system. So at this point, I'm just going to pivot to here so we can have a chance to hear from Beckie Beckie Byrne is Associate Director of Transformation at Lewisham and Greenwich. And I think what's really valuable, Beckie, about you joining us is also to bring that kind of below board perspective, someone working into the board, about what you feel boards could do differently to really unleash further progress on this topic. So Beckie, over to you, and then we'll pick up questions that we've left hanging after Beckie's spoken. Thanks, Beckie.
Thanks very much, Jenny. Hope everyone can hear me okay. Yes, a shame to cut that Q&A short. I was enjoying that, but I'm sure we can come back to it. I quite like the way of describing me as below board. It sort of makes me sound like I'm pushing up on something, trying to get out, doesn't it? I think I might take that description back. Thanks for that. Are we able to move on to the first slide? Is that okay? Whoever's controlling those for me, thank you. Oh, sorry, the next one. There we go. So look, thanks for having me today. As Jenny said, I was kind of asked to come here and bring an improver's perspective to doing this work across providers and also focusing on kind of inequalities. And just kind of a bit about me, I've been at Lewisham and Greenwich about 9 months now, so actually not that long. And although I've spent 8 years in the NHS, it's not my background. I've worked in kind of, this reason I put this slide here, I've worked in more or less every part of the public sector you can think of. And the reason I highlight that is because I think for me, you know, working collaboratively across boundaries is kind of baked into how I've worked across my career, but that is often not the case for a lot of the people I work with. And it is tough. When you've been in the NHS for a long time, you know, you develop great expertise in what you do and the way that you think, but it can be really hard to look outside of those boundaries and work with others. And hopefully I'll give some tips today on sort of my experience from all those different places of how we can do that together. If we could move on to the next slide, please. I think I was putting this together on a Friday afternoon when I'd sort of lost inspiration, so apologies for the slightly cliched set of photos. But what I loved in my speaker brief for this is that I was asked to talk about both the emotional and practical of how it feels to be an improver in kind of complex system space. And I think it does feel much like this, actually, although it is slight cliche. I'm often given that blank sheet of paper. You know, I'll have a sort of passing conversation with an exec or somebody senior to say, please can you come and help with this problem? And that's you know, that's all I'll get. And actually it can feel like you're starting from scratch, although often the work itself is not starting from scratch. But the point of including this really is that, you know, as we all know, improvement is messy, but I think particularly when we talk about using improvement methodologies across multiple organisations and focusing on inequalities, there is so much there. And, you know, often it can feel like you're kind of bouncing around the system, talking to lots of people, having lots of different conversations, looking at lots of data, looking at lots of approaches, and trying to kind of wade through that emotionally can be quite challenging, and particularly when you're kind of navigating complex politics, difficult behaviours, different ways of doing things, different ways of working. What I wanted to say on the emotional point is that what is really helpful from a board perspective is actually the simple things. It's the encouragement, it's the text at the end of the day that says, that was tough, well done, or those kind of side conversations that give you that motivation. I think we can sometimes overthink those things, but actually they take kind of 2 seconds, and certainly in my role and my team's roles have a really, really big impact. I'm fortunate to have a board that is great at this. It is why doing this job in this organisation is better and different for me than doing this job in other organisations. I have that support. I have a board that's really improvement focused and takes the time to do that, and it does make a huge difference. I'm not quite sure we ever achieve the Sistine Chapel vision, but nonetheless, I thought it was a nice illustration. If we could move on then to the next slide. I won't talk about this a lot because this doesn't really kind of get to the practical tips, but just wanted to highlight some of the bits of work that I'm involved in from an improvement perspective when it comes to thinking about both working across providers and also reducing inequalities. And Bob and Andy have touched on some of these examples already in their work. So we have a community diagnostic centre that we're leading as a trust that has recently opened and is mobilising at the moment, which is obviously system capacity with a particular focus on reducing inequity and access to diagnostics. I host a Lewisham integrated programme team, so that's a new team for us that hosted by us as a trust but works across Lewisham as a borough funded by the ICB, so very much a place-based model of working. We also provide community services in Lewisham, so we're quite well placed to take that on. high volume surgical hub, we're also mobilising a high volume surgical hub at our Lewisham site. So again, big focus on reducing inequalities in access to high volume, low complexity surgery. And then final example I've put here is we've recently won some Q Exchange funding for our work around health inequalities in waiting lists. And we're fortunate to have a great population health system. To some of the points Andy's made about data, we do have good access to population health data, which makes a world of difference. So we have quite a well-established health inequalities in surgical waiting list programme. But what this funding is enabling is for us to work much more in our place-based system to co-produce solutions with community groups and with residents for patients that we know are experiencing the biggest inequalities in access. So that's a really nice example actually of where bringing a programme, our improvement methodology and our work kind of around co-production together is having a huge impact. So if we could move on to the next slide, please. So this is where I wanted to focus most of the time. Hopefully you can all read that. If not, it will go out after, because I think I was asked to give a view on the kind of the high impact things that I think board members can do that make a difference. These are from my experience. I'm sure they look and feel different in different organisations and different contexts. Although I found these things to be consistently true in most places I've worked. And I should probably start by saying here that what I'm about to say does depend on having that core improvement infrastructure in place. We have that. I'm sure that works to varying degrees in different places, but I suppose my advice would be at the first stage is to really understand how improvement methodologies do work in your organisation or your sphere of influence. Do you have an improvement team that your board feels they can trust? Is it working on the things you think it should be working on? Is that embedded in ways of working across the organisation? Do you have the right skill sets and behaviours? I think all of those things are really important to probe. We've recently brought our improvement team together with our programme management team into one transformation function. For us, that's made the world of difference. It was working well before, it's working even better now. So I think looking at some of that core infrastructure is really, really key. And then assuming you've got that, the place that I always say to start is getting the data in the right format. And again, Andy and Bob have touched on this a little bit in their presentation. For improvers, if you're using kind of quality improvement methodology, what tends to be recommended and I use is something called SPC charts. So for those not familiar, that stands for statistical process control, which is it's essentially a run rate chart, but gives you a really visual way of seeing whether statistically your metric is improving or not improving. And actually the national templates for that are great because blue dots mean you're doing well, orange dots mean it's not quite going where you need it to. So if you're not familiar with that, I think that is absolutely key for a board member to understand what an SPC chart is, how it works, and to request that. I think if you're doing an improvement piece of work, you shouldn't accept anything less. I would say, frankly, I think that, starting with that as your baseline data, it gives you, particularly when you're involved in so many things at a high level, a really nice visual way of knowing whether the work is or isn't making a difference. And if it's not, where you probe further. If you're not familiar with that, I'm sure many of you are, there is some great national resources, something called Making Data Counts, which you can Google, find online. And also the national team will come out and do training. They target training at boards. So if you haven't done that, I think that's a top tip from me. Please do. It's really, really simple. Makes a massive difference. You may already have it in your board scorecard, and if so, great. And I think kind of asking questions around that. So the tips I've given on here are, the way that I would probably frame this. So what SPCs will show you is you're probably still miles from the target. Unfortunately, we often are. But actually, although we're not hitting that target, do we know if the interventions we're making are at least edging us closer to that? And that just helps have a more intelligent conversation instead of looking at, kind of sea of red rated performance metrics that I'm sure we're all familiar with. So then assuming you've got the data, I think probably the best next thing, or the thing I find most helpful, is if board members have a kind of broad understanding of one or two improvement tools and approaches that they like the format of, they think are effective, and consistently recommend them when work comes up to board level. So most likely or not, a project has started and kicked off and it's doing some great work, but actually it's in a kind of typical project management format, might not be telling you a huge amount of information about the problem and the kind of logic, I suppose, between the problem and the data data. Improvement methodology is great for that. If your organisation has training for leaders, we do that. We do training targeted at kind of, I was going to say below board again then, so board and below, but essentially senior leadership. It doesn't have to be any particular tool. Different things work for different people, but you know, I've had this in board meetings where somebody will say, great, can you go off and work with Beckie on a driver diagram, for example? Can we do a process mapping session? Can we see that back to you in 2 months' time? So actually really baking in those improvement actions at a board level can make the work of the improvers much easier, because it gives them the leverage they need to go in and work with clinical, operational colleagues, patients, public, whoever's involved to embed improvement. The other thing I want to say is that I guess it's sort of about training more generally. I think we can get a bit focused on our own internal training and training our own staff. Actually, we offer ours across the system. I think particularly when it comes to ICB colleagues, actually, often they can't access quality improvement training, or if they do, it's through a national infrastructure, takes longer, slightly clunkier. You know, I'm a big fan of quick and easy. So if you offer improvement training, can you offer that across multiple providers? Can you do it for your patients? We have patient improvement training. Can you bring in your ICB? Can GPs attend? I think some of those things are really quick wins that just get people talking the same language around improvement. And then I suppose the final thing I'd say is more specifically then about working across providers and working on inequalities. Only sign off projects that embed addressing inequalities. So, you know, you've done all of this, you've embedded improvement in the work, brilliant, that's great. But actually, if that project isn't intelligently looking at how can this issue be made better for people that are struggling to access it the most, then should we be running it? And I think, you know, we often have EQIAs that come through boards, you know, every organisation, there'll be something likely that comes up through our reporting. But how often do we actually say, we're not going to sign that off unless we have a clear understanding of what our data tells us about the groups this is disproportionately affecting and what we're doing to improve that? It's simple, it's effective, and it makes a big difference. The other thing I'd add on that is, again, you know, if a project's kind of coming through for a recommendation or approval, can it be done across provider or place? You know, we think about that with our work in reducing inequalities in waiting lists as we get a high volume surgical hub up and running. How do we change that work so it's not just focused in our own organisation, but actually working across collaborative boundaries? That work for us is already place-based in terms of being in our local system with community partners, with the voluntary sector and with patients, but actually could we do that bigger and better? And then finally, I think really important point, although I've included it right at the end, this was something when I asked some colleagues who are working on these kinds of projects, what would they say? They said actually governance is a big thing for them. So, you know, with those kind of big improvement programs that span multiple providers, signing up and sticking to shared governance arrangements is key. Otherwise, you get stuck in reporting through, you know, potentially 3 or 4 boards, taking things to multiple meetings and forums, getting a different steer in different places. Sometimes we have to do that, you know, it's not that easy to come up with shared governance that completely bypasses that, but actually being really clear on, if this is a system project, how much decision making can we delegate to that project board, and how much do we then still need to take through organisational governance? I think that makes a huge difference. I'm not sure how I've done with time, hopefully that was okay, but I think I'll stop there and happy to take any questions.
Beckie, thank you so much. Another fantastic presentation, and also I think fantastic to have those really practical insights on the questions that board members can ask, what board members can do. I can see a whole load of things we can do with that slide to take that those key points out to a board audience. So we will definitely pick that up after the session. So let me just come back to the chat and for questions, and you know, do feel free to put questions in the chat or to raise your hand. Question here, I'm afraid I don't know this first name, but Walker, really interested in hearing more about the improvement training provided to patients. Could you come back on that one, Beckie?
I can, yeah. So this is something we've run for a while now. I'll be honest, we need to improve the take up of it. I think that targeting the right people still kind of remains a challenge for us. But we have a target in our annual improvement work plan to, I can't quite remember what the percentage is, to have a certain percentage of projects that have what we call big I and little I involvement, which is kind of language used in the QI methodology that we use. So we offer Microsoft Teams based training in an evening to any member of our local population. It's advertised on our website. It's really kind of quick and simple and just talks through some of the key methodologies and approaches that we use, and then gives those patients an opportunity to get involved in a project that matters to them. So we will then have those patients sitting directly as part of that project group and working as part of that improvement cycle. Happy to share a little bit more information. I'm sure I can get the pack of what we cover and send that around if that's helpful.
Thanks, Becky. Great question and great answer. So I'm going to bring in Stella, who's been incredibly patient. Thank you for that. And then also Naomi's put a great question in the chat. That was one of the things I wanted to raise about what this, we've talked a bit about place, but what are the opportunities across provider collaborative? So Stella, to you first and then Naomi. Oh, sorry, just got your mic muted, Stella.
You're quite right. There we are. That's better. Good morning, everyone. I'm chair of University Hospitals Coventry and Warwickshire, and hence part of the Coventry and Warwickshire ICS. I suppose mine is more a comment than a question. It's just to say my experience is not that there is any resistance from the board to this. Our board is completely committed to tackling inequalities, and I think that would be true across the majority of the system as well. For me, the issue is how strategically and operationally both ICSs and individual institutions address this. Because I suppose my fear is that in the enthusiasm and in the let every thousand flowers bloom instinct, you end up with a lot of fragmented initiatives. And I suppose what I would plead for is that, you know, there are different layers of looking at this. And in fact, all three presentations and discussions have illustrated that extremely well. So I would say there is what you do strategically. And so, for example, we've talked about waiting list management systems. We've got one that has been quite well promoted, HEART, won the HSJ award, blah, blah, blah. You know, and different people are obviously doing things like that. And that can be, if people buy into it, a kind of strategic initiative or an individual institutional initiative. Then you've also got what you do geographically. You know, how are you targeting different geographical areas of deprivation, and what exactly are you going to do with them? And I would just pose, for example, the question of a number of us have got money for community diagnostic centres. Well, that's great, and we all concentrate on building that or setting it up or whatever. But the key issue is, how is the access to those community diagnostic centres going to be managed, rationed, whatever word you want to use for that? That, you know, there is a lot of kind of operational stuff that needs to go to that. And I suppose what I would imagine is that for every ICS, you're going to have a number of layers of things. You're going to have things that you do strategically, things that you do operationally as individual organizations, things that you collectively agree to focus on geographically, and some of the things, for example, what Andy mentioned, which was, you know, the DNA rates and so on. You might have a specific initiative for a year to try and embed a process that reduces that or whatever, but that's about specific initiatives. And my worry is that a lot of what is happening at the moment is extremely fragmented without a kind of overview that's kind of drawing all that together. And then I would just finally throw in one thing before I shut up, which is that one of the things we've recently done as a single institution, as University Hospitals Coventry and Warwickshire, is to give ourselves a strapline, more than a hospital, in our new organisational strategy. And that is because we are trying to symbolise being a more outward facing thing rather than those shiny buildings in the northeast of Coventry or the buildings in Rugby or whatever. Because if we don't get into that space of going out into the community or into various communities, then actually we still won't break down those barriers of both working with different populations and or working with different partners. So I'll just throw that in as a kind of symbolic issue at the end, and I'll stop there.
Stella, they're absolutely fantastic points. And I think that's absolutely right about if we're going to get real bang for our buck, how do we take that strategic approach and ensure that it's not just a bottom up, there's a strategic grip on what's happening at different levels of the system. And I'm wondering, as part of that, so one of the things we're looking at in this programme is what's the role of provider collaborative. So what's happening at system level, what's happening across provider collaboratives working at scale, and what's happening at trust level if we recognise that this is something that needs to be mainstreamed in everything we're doing. I wonder if I could throw Naomi's question back out to Andy, Bob and Beckie just before we wrap up, about what do we think the opportunities are at provider collaborative level to really kind of mainstream this focus on continuous improvement with equity at its heart. Bob, tricky question.
Yeah, we're sort of
first, and then
channeling Stella's question within that as well. Yeah, okay.
Yes, that would be great.
So it's fantastic. Such a live issue. First thing I've got to say is we've spoken to our team and we're taking up the heart tool, which we think is fantastic. So simple, and so we're really excited about that. So I guess that's one example where we want to be an early adopter of good practice. And I use the example of Provo Huddersfield around learning disabilities. There are other examples I could use. So strategically influencing, because my last job 14 years ago was running an IKEA, which has a standardized, I'm not going to go on about industry, but like a standardized approach, sort of globally regards to language and culture. And we struggle with differences between Barnes and Rotherham, never mind anything else. So influencing people, because the ICS level, whatever the configuration is, you can only go at the pace of the slowest. But if you ram it down people's throats, you've got to kind of show them and influence it. The money coming in, crazy way that we're funded, but the money's coming in is haphazard, so therefore the planning is often haphazard. But what we're finding is that we're buying into joint solutions. So we've got a great community diagnostics centre in the centre of Barnsley, which we're really proud of. But actually we're working with Doncaster and Rotherham at a community diagnostics centre in Mexborough, which is we'd looked within the challenge geography within Barnsley. We, despite the aspiration, we didn't have the infrastructure to support the model, the ambition of the model that we had. But we realised by working with Rotherham and Doncaster in an existing, almost a kind of community-based hospital, we've been able to do that. And I'm actually at a meeting this morning about a new elective hub we're doing in the same geography, which help with orthopaedics. And getting that share, I'm hoping the heart list will help with the kind of the shared waiting list and how we prioritize patients. But you kind of feel like you're making pace in one organization, then you start speaking to operational leads in the other, and you realize despite the aspiration, people aren't quite there. They're not using the same language, they're not measuring it quite the same way. So I would really advocate for a standardized approach, and we've invested a lot of time in South Yorkshire. I think the team are getting there. They've not, I don't think in South Yorkshire we've invested as much as we should have done in this area, if I'm being honest. So I think there's a challenge to all of us as board members, senior leaders, influencers, to kind of shape the thinking around that. And that's kind of as far as we've got strategically. I'm sure Andy and Beckie will have views as well. So
Thanks, Bob. Beckie, can I bring you in for reflections from your patch? I mean, I know you've naturally worked across boundaries, looking at that slide that you had an impressive range of partners that you've covered off. But any thoughts, particularly on the provider collaborative
Yeah, and I suppose the first thing I'd say is that when I hear provider collaborative, I don't just think about the acute, and I think we do still have a tendency too much to equate provider collaborative with APC, and that is important, absolutely, but actually providers includes primary care, includes community services, includes the voluntary sector, includes local authorities, and I do think we have to challenge ourselves collectively to really mean that wider collaboration when we talk provider collaboratives. But I did talk about more place-based work than the other stuff. We do similar to what Bob's just said. I think our main focus is our community diagnostic centre. As I said, that's recently mobilised. That is a huge opportunity for us across acute providers. That is in the early stages, and I think so. What we've done in terms of embedding improvement methodologies into that is we've started with a tool called the sustainability model. I don't know if anyone's come across this, which is a national improvement tool, because that's been a kind of large program to this point. Actually using that improvement tool has given us a kind of output that shows us how sustainable the improvements they've made so far are against various domains, and we're then using that to help us identify where we need to apply further QI methodologies and approaches in collaboration with other acute providers. And similarly, we'll take the same approach to our work on theatres, which again is an APC priority. So I think there's diagnostic, well, our elective pathway essentially is probably where we're focusing more on that more typical acute collaboration. It is not necessarily trickier to imply improvement methodologies. I suppose what's trickier is that we all train in slightly different ways and different approaches, and people can get quite hung up on this is how we do things here. I don't see that so much in my local patch, but certainly in past experience, I found that's where things get stuck. And that's why I guess my main tip was keep it really simple. Just pick one or two things that you want to do together and one or two approaches that you're going to use. Otherwise, you can get caught a little bit in, oh, well, we use lean, we use model for improvement. It doesn't really matter at the end of the day.
Thanks so much, Becky. I'm kind of very conscious of time in case people are leaping onto other calls, but there is more questions in the chat. I think we could have gone on for a lot longer, which is a good sign because this is the beginning of a programme that's running for 18 months. So what I'm going to suggest is that we take some of the questions in the chat that we didn't get to, and we'll go back to the speakers to, or if they've got a moment to kind of pop any further thoughts in the chat just as we're closing, but we will pick up some of those questions that we didn't get to fully in this session. I'd like to really thank so much our three speakers today, Bob, Andy and Becky. It's been inspiring and humbling to hear about the work that you've been doing. I don't know whether it's right to even attempt to kind of summarise, but I think there's a fantastic message from Andy about this isn't just about social justice and ethical perspective, it's about part of the solution to the operational challenges we're all facing in terms of managing demand, and the focus on that mindset shift. Bob, there's some great messages for you about the importance of board leadership. Everyone has a key role to play. It needs to be a joint mission pursued in partnership, really clear vision, narrative, making sure we're speaking to staff in ways that make it relevant to them. And that point about really getting into the detail and moving upstream about who's actually accessing services, not just the usual performance targets. And Becky, I mean, your slide, as I said, on the high impact actions for board members, we will come back to you on how we can really mine that for all it's worth. And I loved your kind of let's not overcomplicate this when there is a lot of complexity in terms of encouragement, some of the simple things that board members can do to build momentum and keep people going, and baking improvement tools in at board level so people really know the questions that they should be asking. And that point about enabling governance and only signing off projects that embed addressing inequalities, and have you got a board that's bringing that lens into its work. And Stella, thank you, having been so patient. Just a really powerful point about the need for a strategic approach and what happens at the different levels of the system. And that's also very much part of NHS providers thinking in our kind of influencing and conversations on the operating framework roadmap and what's happening next with the role of ICBs, provider clubs and trusts. So thank you so much to everybody. We're just putting a link in the chat to get your feedback. If you've just got 30 seconds, just pop any questions in the chat, or do, if you have got a minute, complete our survey, because where this programme goes will be driven by what you say to us. We recognise this is kind of early days and people are, as Bob said at the beginning, stealing with pride, hopefully, about what progress can be made at trust level, and then thinking at Provider Collaborative Level 2. So do please give us your feedback, and that will inform our future sessions. Our next session webinar is up in September, but we will send you further details in the post-event email. But thank you once again for joining us when I know it's such a busy and pressurised time. It's been a really rich discussion, and hope you'll join us at future sessions. Thanks all.